Good afternoon, everyone, and welcome to this Scrutiny Management Committee public hearing session with the Committee for Health and Social Care. So today we'll be focusing on many of the issues contained in the committee's mandate. I'm Deputy Yvonne Burford, and with me on the panel are Deputy Simon Fairclough, Deputy Andrea Dudley-Owen, Deputy Peter Roffey, and Senior Scrutiny Officer Suzanne Leray. Following this session, the Scrutiny Management Committee will decide if any further review activity relating to today's hearing will be undertaken, and a Hansard transcript of the hearing will be published on the website in due course. Please also be aware that this hearing is being live streamed, and a link to the live stream is provided on the website and on the Scrutiny Twitter feed. We'll take a short comfort break at around about 4:30. We've got a lot of ground to cover today, so we would be obliged if witnesses are able to keep responses as concise as possible. So if everybody would kindly ensure that mobile phones are set to silent, I will now turn to our witnesses today. Would you please introduce yourself, starting perhaps with Dr. Raby? Thank you.
Dr. Peter Raby, Medical Director for Health and Social Care.
Deputy Mark Lebby's new Vice President of Health and Social Care.
Al Barrard, President of Health and Social Care.
Dermot Mullen, Director of Operations for Health and Social Care.
Thank you very much, and congratulations, Deputy Leadbeater.
Chair, would it be helpful just to run through who we've got in second row who may be asked to help?
I think if you wish to call on anybody, perhaps you could introduce them at the time.
Fair enough.
Thank you. Right, so we'll go straight into questions on the Partnership of Purpose and Public Health. So in 2017, there was a policy letter on the Partnership of Purpose was accepted by the states, and it stated that based on extensive modelling, unless changes were made, health and care costs would outstrip the available funding within 10 years. At the last hearing with your committee last year, we were told that it's going to take at least another 10 years from then, so that's from 2023, to implement. Does the President believe that as a matter of urgency, work should now be accelerated on the propositions in that policy letter?
I think generally Partnership of Purpose is all about providing sustainable healthcare in the future. And there are a couple of unpleasant truths, unfortunately. And one of them is that we are going to need, and I think most of the Western world is in the same position, more capacity with regard to health and social care generally, because we've got the silver tsunami coming through. I'm probably one of the bald-headed tsunami part, but the numbers are just increasing. No matter what else we do, the numbers that people will require treatment or care is going to increase. So staying still is not going to be an option. Treatments are improving all the time. Not only the actual procedures, but new drugs are coming on stream that will all require funding. And then, of course, regulation and the way things are done, of course, is a lot more complicated now than it was 20 or 30 years ago. The issue will come is who pays. Now, whether we do it privately and people have to find their own funds, or whether it's a public offering like the majority that we have now, that's where the dilemmas are going to come. So that if we don't address both of those two issues, one, the capacity, and two, how it's going to be paid for, we're going to have people who will be needing treatment but that won't be able to be served. All the elements of the Partnership of Purpose all feed into that. Some of the ones for capacity, things like the extra extension to the hospital, really, really important. Things like a lot of the Partnership of Purpose is all about communication. Communication is key. Electronic patient records is one of those very first building blocks in that particular area, so that we can start to link different services together. And we're trialling the position in Alderney, where we've got the Alderney Care Board, and we're trying to bring the hospital, the doctor's surgery, and the care home in one collegiate working together partnership. And we've got some really good partners at the moment, both with the MSG and with doctors. And I would warn anyone, if you break what we have, because we've got a very good service at the moment, although it's under pressure, make sure you've got a replacement ready to take over, because we've seen what happens with other areas of the states where we've dismantled something, but we haven't then had the wherewithal to put it together that people have treated.
I don't think anyone disagrees or doesn't understand that it is going to cost more. I think, the ageing population, new treatments, increased demand. We all understand that. But I suppose what I'm trying to get at is what is being done to mitigate that, to do things more efficiently, so that, you know, those costs are as little as they can be, even though they're going to clearly be there.
Yeah, you're right, but please don't hang on to that efficiency is going to save us. It is not. There are things we can do to be more efficient, and I'll ask Dr. Brink to comment, because where there are things we can do to prevent or lower the curve that we can see coming towards us. But efficiency won't cut it alone. We have to the things that will help are things like increasing capacity, in other words, the hospital, working more collegiately, like we're trying to bring the community hub together, which is, you know, the new facilities that we hope to have in Longrue. All that is all part of that journey. But, you know, even the states recently, you know, we're pushing back on the hospital modernisation. We haven't progressed as fast as I would have liked on the community services, but they're all in our gift. But we've chosen to take almost an easier route of passing it on to the next group to do. But Dr. Brink, you've recently given us a paper. I think you've got a presentation to states members about this very idea of suppressing the curve that we've got coming towards us.
Exactly. So we're under direction from our committee. Deputy Broward came to us and said he would like us to look at how prevention is modelled in the Guernsey context now, today, looking at both longer term, but also what happens over the next 20 years or so. And what we've done is we've taken a set of different chronic conditions and looked at how we can flatten that curve. So we know that from 75 plus, the curve of multiple diseases goes up very significantly. So what we're looking to do, and what we will be presenting to deputies on the 15th of May, is our vision for how we would flatten that curve. So, but that's not to say things have sat still now. So, for example, the committee has supported the implementation of diabetic health checks. That affects more than 2,000 islanders. Now, what that does is it detects a problem early. So if you look at diabetes and the development of kidney disease, managed early on, managing kidney disease early on is far cheaper than waiting until someone needs dialysis. So you've got the very upstream preventions like looking at keeping people healthy, but we mustn't forget the secondary and tertiary prevention, which looks at people who have a problem and how we can minimise that problem and minimise the impact on health and care services, but also improve that person's quality of life. Don't that answer your question?
Yeah, thank you. I think perhaps also, Dermot, can I bring you in on the partnership of purpose and what we're working towards?
Yeah, so I think, as you quite rightly say, it's what measures we're taking in terms of not having expenditure at a level that is projected to go, and what steps we're taking in that. I think more broadly what we've done, and Dr. Brink does it in terms of Public Health Alliance with Jersey counterparts, but we're also working more closely with Jersey Health and Care System about what keeps island operating contexts resilience in times like pandemic, but also in terms of modelling. Are there things that maybe both islands do now that we wouldn't both do in the future? So more of a shared care model across a pan-island opportunity. In fact, we have, I think it's about the 13th of May, we're also linking in through the Normandy office in France, both Jersey and Guernsey, to look at what the opportunities potentially are to work more with our French counterparts. And the first part of that's around resilience in terms of air links for lift and shift and medivacs from within the islands, but also more broadly, are there opportunities to think more strategically around partnering with both islands, but then into the French system. So there are lots of strategic opportunities being explored. I don't think any of them be delivered overnight, which, as you quite rightly say, is why we were honest last year and said, the pandemic disrupted the partnership of purpose from 2020 for 2 years. So that was a lot of time lost, and it's about what we can do over the next 10 years. But the partnership purpose has never stopped. There are lots of work streams going on, but it's against the backdrop of that bigger question of what sustainable health and social care looks like across the bailiwick.
If I
Okay,
can
thanks.
just ask the Vice President just wants to add to that.
Well, we've got a list of kind of strategic areas we're working towards, the partnership of purpose, and operational areas as well that we've got down here. So work is progressing on certain areas of the partnership of purpose, but as Dermot outlined, I think COVID kind of chucked a spanner in the works for a lot of the transformational pieces. Clearly, we've got the OHM project, the EPR project, and the Children and Families Hub, because they're very key to the transformation of the services we're going to be providing. But we've got the alliance with the Jersey counterparts that I think that Dermot's alluded to, and clearly we've got the mental health and wellbeing strategy steering group, which is going to be releasing its first annual report coming up in the next few months. We've got the Healthier Weight technical team. So we're progressing in these sorts of areas, and the combined substance use strategy
So
also.
can I just ask, I don't know if you followed the hearing that we had with P&R a few weeks ago, and during that hearing on the topic of the partnership of purpose, including the key area of the universal offer, Deputy Salisbury said, and I quote, "We cannot let it drift any longer. We have got the model, we just need to put it in place." So as the committee responsible, can you advise us if you think that is a fair comment, and has it been allowed to drift?
It hasn't been allowed to drift, and I think it's probably, I may say so, probably an unfair comment. The idea of the partnership of purpose is exactly what we're working towards. There are a load of building blocks that you have to have in place to make it work, and it's absolutely, we are working towards it. Yeah, I think it's a very unfortunate comment, and I think from we could provide scrutiny, if you want, now or later, with copious amounts of evidence of things that we're doing on a daily basis towards the partnership of purpose. But again, if you're doing the really big picture stuff, which may mean changing the system completely, whether you're going to go all private or whether we're going to stop employing different people, make sure you have something in place before you break what we have, because we've got very good services at the moment. At A&E, you can get seen very quickly. You can be seen by a GP very quickly, and we've got some very good services through the MSG. So I just want to make sure that we don't damage what we already have. But there is a multitude of work, and we could do more if we had more resources, obviously, to put towards it. So I don't take that comment. I think it was very unfair.
Okay, and one of the components of the partnership of purpose is the definition of what services are delivered without charge to the public, in other words, the universal offer. What do you believe could be excluded from the current offering, and should charging for certain items which are currently free be implemented?
Yes.
Would you like to give us some examples?
Yeah, well, I mean, some, and again, these are ones that have come through P&R and the initiative to ask for ideas from the public. But if you take whether or not the public will be acceptable to it, or even to politicians, but charging at A&E costs us roughly £4 million a year. We recoup back about £2 million a year. It's a private service from that point of view. We could increase the fees there. Do we necessarily need to have free pills and potions for those over 65? That's another area where we could look to, increase our income. Should we have our pills and potions at the same levels that they have in the NHS, which is probably double what we're charging? There are some very big ticket items, but we are also
prescription charges.
Charges. But there are some very big, the £12 grant to doctors. Is it really providing the service that we want it to do? But changing those are quite difficult, and it would need the support of the states, because we know from when we tried to just move very gently on cancer care and A&E what the backlash from our public was. So there are some very, very big ticket items. We're very happy to have those debates and put them forward.
Are you going to be proposing any of those things this political term?
I hope so. I mean, and they are part of the I can't remember the exact name, but there's a group through savings subcommittee through PNR, and that's where they're going to be coming forward, and hopefully with PNR support we'll be able to put them forward, because that funding will be very helpful.
So can I, yes, go on.
Just to pick up on that, we're also looking at various different ways we can encourage or compel people to use their medical insurance, because at the moment we've got a considerable amount of people, islanders, that a lot of them get, certainly in the finance industry, for etc., and other industries as well, will have medical insurance that comes along with their job. Many people don't use that medical insurance. They will often get a kickback from their insurance company to not use that medical insurance. Now, if we could find a way to encourage people to not do that and to use that encourage, or even if we can compel them to in some way, that will make a considerable dent in our budget, because it's difficult to put put a finger on the number of people that we're seeing coming through our hospital and our other services that could be paid for by their private insurance, but paid for by the states. So that's one piece of work that we're trying to look at, and we'd like to bring some proposals to. If we can get some, it's difficult because we've touched on this before, and we've had advice that we can't compel people to use their insurance. We've got conflicting advice here at the moment, so we're trying to examine that as thoroughly as possible.
I can see how that could be difficult, but perhaps, the kind of amount that they would get from the insurance company for not using it, would you be considering paying that instead?
I think that's a suggestion that was discussed at the committee recently.
Yeah, there was, on Tuesday this week, one of our members very kindly came up with an idea, and it's something we're going to have a look at to see if we can.
Thank you. Can I just come back briefly to the issue of preventative healthcare? And this picks up really, I think, on a comment that Dr. Brink made at our last hearing, which you said that, we can always do more, and I think everybody accepts that. But do you consider that you have actually allocated enough of your budget to preventative measures?
That's a very difficult one when we're running hot already. I mean, we are already this year, we will struggle to meet the budget we have. The difficulty is, where do we take it away from if we want to then put it into preventative facilities? But this is one of the areas where we've asked our team to see if there are things we can do, and hence the presentation to States members shortly, to see if we can release some further budget to do the preventative, because people. It is really useful to do it now, but it's much easier to always deal with a problem when someone turns up at A&E or they need a long-term bed or whatever. But Dr. Brink, do you have anything extra to add to that?
Yes, thank you, Deputy Brown. So I think the point about preventative health and care is this is a whole island issue. It's not just a health and care issue. And I think we need everyone to sign up and look at how we, as a community, can deliver that good preventative healthcare. Take, for example, physical activity and the impact of access to physical activity does for people's healthcare. Access to a healthy diet. So if you're looking at some of those very upstream measures, which are incredibly cost effective, you get a good return on your investment, is we need that whole islands approach. And that's one of the themes we're hoping to bring out on the 15th of May. It's something that we all need to sign up to, and it's not simply a health and care problem. I don't know if that makes sense.
No, I think that does. And I think the Health Improvement Commission, if I'm right, does look at a holistic approach to that. But is it the case that the Commission is purely funded from HSC's budget, or are there contributions from other committees' budgets?
I think ESC contribute towards the HIC budget as well.
Right, okay, thank you.
And E&I.
And E&I.
Right. Okay, I can pass on to Deputy Dudley. Oh no, Deputy Ruffy, you're trying to get in there.
Technical issue, because if Dr. Brink is contributing, my concern is that because there isn't a microphone in front of Dr. Brink, that the content might not be captured on Hansard. So I was just wondering if Dr. Brink's going to be a panellist that you're calling on. Yeah, just because you can't hear on the micro.
I appreciate that. With the size of the organisation, the mandate we have, I'm very likely to call on our second row, which is, basically our first class row.
I understand that. My concern is that it won't be caught on Hansard for.
Yeah, we can make some room on the top table here for someone to
come up alternately. Okay,
yeah,
thank
no
you.
problem.
Thank you, Madam Chair. I just wanted to refer back to the answer to your very first question. when Deputy Brewer, you said that a big increase in costs are unavoidable. The real question is who pays for it, whether it's the states, which means the taxpayer, or whether it's the individual. And I really wanted to know what thought you put into that as a committee. I mean, you're clearly being very brave. You're talking about increasing accident and emergency charges, which most people find very high. You're talking about removing pensioners' access to free prescriptions, and I've forgotten what the other one was, but there were three that I think are going to make big headlines here. But picking behind that, just what is your general philosophy? Do you sit down and talk about, going forward, do we need more and more money from the taxpayer to keep the health system going, or should we be moving to a more American model, if you like, or whatever model where people are more responsible for funding their own healthcare?
The difficulty we face is that we're having our budget curtailed, as it were, compared to the demand. I mean, the demand is almost exponential. I mean, if you just take ED, we're 8% to 10% for the last 3 years increase. That is phenomenal. And that's just the tip of the iceberg, because that will then feed in later to more people needing hospital beds for even longer. Procedures, we've done 14% more procedures between 2002 and 2022.
I'm asking what you see as the solution going forward.
Well, the solution,
if you're not going to get the budget, how are you going to charge public more?
Well, this is the dilemma we have. I would like to see islanders treated, and I would like to see it on the public offering. I think, and I voted for the GST amendment. I would like to see more funds put into health. I think that's the fairest way of doing it. I wouldn't like to see us going to a private offering where people have to either sell their houses or have to rely on their bank balance. I would rather we provide it publicly. But the difficulty is, we're not being. I don't think we've got the capacity to give the funding that we're going to need. And we're seeing it today. It's not tomorrow. We're seeing that pressure now. So we've got some really awkward decisions. Do we start? I mean, I've got a waiting list which I would like to clear by 2025.
We'll return to that.
Yeah, but each of those comes with a price tag where I can't get the money to do it. I haven't got the capacity in the hospital to do it. I haven't got, a second laminar flow theatre, which I need to get the orthopaedics through. All these things. So if you push me, I will have to put up fees. I would prefer not to. And I would prefer it to come from the public purse, generally from general taxation. That would be my. But if you give me the choice that you're not going to have it, but I've got people suffering who need to be helped, then I'm afraid somebody will have to pay. That's probably how
we're also looking at we had the start of the primary care review earlier on this term, but that was resourced outside of our committee, and the resources had to be taken somewhere else. So that was not something that we wished to stall. It was just a case that the resources centrally were reallocated somewhere else. And also we've got the new model of care in Alderney. So I mean that could very well work out to be a pilot for what happens in Guernsey going forward. There are a hell of a lot of transformational things that can take place in health and social care. I'm going to have to take place, because it's not just a case of just chucking more money at it. We have to do things differently. We need the things like the OHM project to be able to allow us to realise a lot of efficiencies up at the PEH. But we need to look elsewhere. We need to look at the amount of agency staff we're using in adult disability, for example, and look at the ways we can encourage people to fill those posts full time. Try and encourage local people there. I mean, I've got an idea at the moment about trying to encourage. We could say if a local person, established resident, wants to come and take on a job that's currently filled solely by an agency worker, they will be first choice for key worker housing. We can try and encourage little things like that we can encourage people, local people, to come into and work for HSC. But it's a big piece of work, and it's not just done within this committee.
Okay, thank you. Thinking about preventable care and pathways, the Healthy Weight strategy seeks a reduction in obesity, in preventable mortality and prevalence of type 2 diabetes. Can the committee report on their progress related to the key performance indicators and how this might impact on the OHM Phase 2 and the need for the diabetes clinic on the scale planned?
That's a very good question. I think I'm going to turn to Dr. Brink on that one. So, Dr. Brink, would you like to come forward?
Thank you for that question. So we've just refreshed the healthier weight strategy, and we'll be reporting on the first set of KPIs on that next year. So it should be Q2 of next year. With regard to the progress on some of the KPIs, we are in the process of establishing a Tier 3, Tier 4 weight management service. Now, as you're aware, that was a gap in our previous service provision. So that's a really encouraging progress. Also, and this really has been good co-working with education, is I'm not sure if you're aware of the latest round of Guernsey Child Measurement Programme measurements. And we are the only place in the British Isles that is showing a stabilisation in weight in the Year 1 and Year 5s. And that's really been an excellent piece of joint work, and we've had good cooperation from the schools. The Health Improvement Commission has been working with the schools. Public Health has been analysing the results. So it's been a joint effort between different political areas and the third sector. And I really see this as key to how we move things forward. There are other areas of the healthy weight strategy, or that we're calling it the healthier weight strategy, that we want to look at. You've mentioned type 2 diabetes. Linked to that is we're measuring the health of our diabetics on the islands, over 2,000 people. Now, this is absolutely key, because you can then put the appropriate interventions in place, whether it's weight loss, better glycemic control, foot care, all of that. And that then takes the pressure off the hospital. So everything we're doing, what we're looking to do is flatten that curve and try and cut off the pressure on the hospital and manage more in a preventative way. So those are all key parts of the health update of the strategy. So in that, we're looking not only at refining our data collection to ensure that we have good local data. We're looking at the prevention, health promotion messages, but also the services. So we're trying to look at the three streams together.
But to get to the nub of that, if there is success with the key performance indicators, does that impact directly the scale of the need for the build of the diabetes area?
So what we would have to do, at the moment we're looking at the effective management of diabetes, and we're looking at weight management. I think it is too soon to say whether that's going to impact on what the scale of need is going to be. Now, you may be aware of what's happening in the UK with diabetic case finding, and really you need to go into that pre-diabetic area to actually have a look at that and look at how you can prevent diabetes actually occurring. So they've got various programs running in the UK with some success, where they look at people with marginally elevated blood glucose, etc., and look at how they can avert diabetes actually occurring. So I think it's what the measures will do is it will help with the impact on secondary care services, but we have to move even further upstream if we're going to want to stop diabetes actually occurring. I don't know if that answers your question clearly.
Can I ask, in answer to your question, you specifically about do we need to have a smaller unit in the hospital modernisation? I think Dr. Raby is probably best placed, because I think the numbers will still be high.
The hospital modernisation programme went through all the modelling before we went into the design phase, and we were pushed to make some very brave assumptions about prevention and about improved social support, improved community support, that sort of thing. We were not confident that those things would be done in time to affect the build, so we've made some conservative assumptions about that. And so it has been considered. We have made conservative assumptions that prevention will prevent some admissions, will prevent some bed days, that sort of thing. We didn't dare to go for the very brave assumptions that we were being pushed to, and I'm very glad we didn't, because so far the pandemic would have stalled that sort of work anyway. But we need in my view, we need a dramatic shift to a prevention agenda in Guernsey, because it won't be, nobody will thank us for it next year, but in 10 years' time, if we haven't done it, we will be in trouble.
That's clear. Thank you very much. Going on to talk now more thoroughly about the hospital modernisation project. Could you please talk the panel through the chronology of what the committee and senior officers knew regarding the significant increase in costs of the hospital modernisation project from early 2023 onwards?
Well, most of it has been in the public domain. The committee was informed on the 19th of December 2023, and the chronology from there plays out. I sent a message to
early 2023.
What I would like,
knowledge going through to committee knowledge.
Yeah, no problem. What I will do is I'll ask Helen O'Hara, who wasn't involved in the original part, but has been part of the solution in trying to see what happened, what went wrong, and why. I think Helen, if you'd like to come up here, and you can perhaps talk through the chronology.
Thank you. Okay, so the key dates were there was a draft cost estimate that came into the organisation, and it came in February of 2023. That was then received as a final estimate at the end of March 2023. That was then shared on the 30th of October. So decision to accept the Breward amendment, going forth with phase 2 with the support of the health reserve funding. That happened on the 20th of October. The report was shared then on the 30th of October, and then we moved into a phase of evidence collation before then presenting it. There were a number of different activities that had to happen in there at officer level, also reaching out to our third party who had pulled together the cost estimate to really understand why there was such a significant difference between that cost estimate and the cost estimate that had been used as the OBC, which was what was fed into the FNIP debate. So there was a lot of activity there trying to work out what was the differential, why, and obviously why it was only shared after that decision.
Okay, thank you. And how was it that the new programme director, who was focused entirely on this role and was the key liaison person with senior management, independent experts and politicians, was not aware of the significant increase in costs when they took up their post last year?
Because it wasn't shared with me.
So how come
it was shared with me on the 30th of October.
And prior to that, you had no knowledge and didn't make it your business to make it your knowledge?
I simply had no knowledge, so I didn't know that there was something that I needed to find out. I didn't know, full stop. It wasn't shared.
Okay. And so the handover between yourself and the previous post holder?
It wasn't shared at that stage.
Okay. So once other senior staff in the department were finally aware of the potential £30 million increase in costs, how long was it before political members were informed?
We informed political members on the 19th of December.
Okay. Was the President informed before that date?
I don't believe so, no.
Not that I know.
Certainly not through me, not through a formal process at all, no. Thank you.
Deputy Brown, is it your policy to ask your senior officers to always make you aware of something that could be a political issue? Because most presidents do sort of say, please, if something could, please tell me about it. But
I'll, without prompting Dermot, I will ask him to say what I said in October 2020.
October 2020?
October 2020. No surprises.
Yeah. Sorry, I get it. Yeah. Deputy Breward did instruct us that there was to be no surprises. I take full responsibility for this. Because of my clinical background, we became aware of it, as Helen says, and I asked for a due diligence to understand, is this really as it seems, which is why committee became aware on the 19th of December. As you know, the head of public services conducting pieces of work looking into who knew what when and the governance structures. I have to take responsibility for that because we didn't verbally make Deputy Breward aware because we didn't have all the detail. We've had a similar situation this week in relation to the electronic patient record. We have verbally informed committee, but we still don't have all the detail of the impact of that. I did say in PNR the other day, good governance or different governance, would it had a different outcome? I don't believe it would, because this was about behaviours. And yes, I accept responsibility for not having verbally briefed committee prior to the 19th of December.
I've got a further question about governance, and I would suggest that governance actually encompasses behaviours and attitudes as well, rather than just process. And following the announcement of the unknown cost increases for the hospital modernisation programme, what steps has the committee taken to strengthen governance and mitigate any future risks of such failings being repeated?
Yeah, just going back slightly to the some of the officers involved were at the presentations when we were pitching to states members to have the hospital modernisation included. How anyone can sit there in that room and not have realised what figure we were asking from the staff who were there also presenting. So the people concerned had ample opportunity to raise or flag any concerns about the costs then. So there was no reason for us. We'd spent many months as a team trying to put together our proposals, knowing full well we needed to go to the States because we weren't included. We were moved on to the pipeline for the next term. So because of what we could see coming up for health, that we needed to increase capacity in the hospital, we put a lot of effort in to making sure that we could get our project into the starting blocks. So there is ample opportunity for staff to advise us whether or not the figures were right or wrong. So that's. But going on to your second point, which was what are we doing now? I'll go to Helen to explain what the review is now looking at with regard to the programme.
In terms of governance, so obviously.
Well, I can mention governance. There's always been a tension between do we have politicians on project boards, do we have politicians on programme boards, which is the right answer? That question has now gone to the head of public service, and he's conducting, I think, he's hoping to publish fairly soon what the findings are from that. And we are very happy to have people on the project board, but as Dermot said, in this particular case, it wouldn't have made any difference because unfortunately that information didn't come across, even at the programme board.
So what efforts have you made to mitigate future risk of any failings in the future?
Well, I mean, the first thing.
Changed the structure of the programme board to ensure that
we've in an interim measure we placed political members on the programme boards. So
as an interim measure.
Well, until we find out what the findings are from the chief executive's report. There's no point us doing it and saying we're definitely going to do this, and then he comes back and says no, definitely not, politicians shouldn't be on programme boards. So this is but I think we pay our professionals substantial sums of money to do a job. We can't do every single job. I have to rely, and so does our committee, on the civil service to be able to come forward with their particular thing. We have asked that, again, there are no surprises, that people are open and feel able to share. I mean, that's the other thing. If we make it too difficult that people don't want to confess when something's gone wrong, and something inevitably will go wrong with an organisation the size of the States of Guernsey, we want to make sure that people feel happy to whistle-blow and say, actually, something's not quite right. But the actual programme now going forward, we're having a review of the pricing, we're having a review of the scope, and all that's being taken care of. And we've had some seed funding from P&R to ensure that does happen.
So just a supplementary based on what you've just said then, so would it be fair to say that the view is that despite this being a significant capital project for the island, not just for the States of Guernsey, also using public money, taxpayer money, that the risk of that possibly going wrong, it wasn't deemed to be important enough for politicians to have oversight, knowledge, even granular information around the project for a politician to be on the board right from the outset that the committee took its seats?
I don't take that criticism. We had the people who were on the team in the room with us, as I think, on 2 states presentations. We can't be any more open than that. Dermot sits as an SRO on the project. He wasn't aware of it. You know, there wasn't anything else we could have done. If someone someone chose not to reveal the information, and it was unfortunate. But of course, this is a stage process going through. You know, that there are, I think, 7 REBA stages. This is one of them. Unfortunately, we have a fairly substantial possible increase in price, but that's part of the, you know, we haven't overspent yet because we haven't even put in the full business case at this stage. We're still scoping out the costs and the works. We haven't involved the contractor to the full extent of actually getting a commissioning in. So, you know, there are lots of steps to go on this. We may find that we're substantially contracted to build it, you know. So, and I think you'll have the same on education, whether or not you can stick to the 88 million. It'll be interesting to see when a contractor comes forward on those prices. But we have asked for updates, and we have had updates, I think 17 of them in the last year, on the project, and we were told it's okay, it's fine. We know, get the 120 million and we'll be okay.
Can I ask a quick supplementary on that? The staff who were aware during this 7-month period that the price had possibly increased by 25% or so, what was the reason for them not communicating that to either other staff or to the political board? Was it because it wasn't deemed to be particularly important or relevant, or was it no? So what was the reason?
I don't think that is, but we haven't been able to find the reason, and I think Helen, you've asked that question and have not been able to come to a conclusion. You've thoroughly investigated, and you still can't come to a reason why it was held back.
Okay.
We have there is reviews going on at the moment, as Deputy Brewer pointed out, and there's 2 reviews being conducted by the head of public service. One looking at the who knew when and why and what, etc., within the civil service. So I'm hoping that that review will tease out.
Well, that's my next question, actually, on this particular review that the head of the public service announced, and he spoke to us about that in the recent hearing with PNR about the governance of major capital projects. That review, we were told, was due to be completed by the end of April. Have you had sight of any draft copy of it yet?
We don't think it's quite complete yet. We've had notification that it shouldn't be too long, but it's still ongoing at this point.
Okay, which probably means you can't answer my supplementary to that about whether you're happy for it to be published, as you haven't actually seen it.
Not seen it.
And it wouldn't be our review to be published.
But more in a point that you wouldn't be objecting to any parts of it that PNR wanted to publish. But if you haven't seen it, I accept you can't answer that question at the moment. Deputy Fairclough.
Thank you. Yeah, in your March statement to the States, you suggested that savings could be found in the next phase of the hospital modernisation programme. What level of savings do you believe could be identified? And if they are available, why weren't they found before?
Well, as with all these things, the whole thing goes through a process. As you go through the different REBA stages, there comes a stage where you do your value engineering. There's a stage where you review all those. We were still at the early stage, I think, of REBA 3.
REBA 2
went
into the OBC. REBA 3 was the new cost estimate.
Yeah. So this is an iterative process that we were working our way through. So all that, finding out whether we could do things cheaper or better, or if we got the right finishes, have we got the right management, etc. That's still in that journey. But your question was specifically about. Yeah.
It's just, as Al says, we've gone from REBA Stage 2 to REBA Stage 3. REBA Stage 2 is very broad in just a schedule of accommodation, doesn't give you any detail whatsoever. REBA Stage 3 gives you a lot more detail. And that's when the cost differential was noticed, but clearly it wasn't elevated as far as the rest of the team in the civil service and also the committee. But REBA Stage 3 is when you can actually start doing a value engineering exercise, because you can see all the detail and then you can make decisions. Well, we can lose that glass screen there, and we can do away with this, that and the other. We could change this finish. So it's not until it gets to REBA Stage 3, which we assumed we were at, to be honest, because we were told we were at REBA Stage 3 and we were told the costings we were given was REBA Stage 3, but it wasn't. So, but now it gets to this stage, and we're not just going out and doing value engineering. We're looking at the design in totality and see if there's, because as I think has been pointed out before, the costings that we've been given have not come from the contractor. So these costings are an estimate that's come from our consultants that are estimating what the cost should be. We haven't engaged with the contractor, and also when you've got a big project like this, very big complex project on a hospital, there's a lot of assumptions been made about what the contractor needs to do to mitigate certain problems as you go on. It's not until you engage with a contractor that you're going to nail these costs right the way down. But this is the stage now where we can, going out back to the design team and even further afield to maybe other design teams, because we need to make sure we get this design right. We don't want to change the scope. If we have to alter the scope, we will do. But the ultimate aim is to provide the exact same scope within the same cost envelope. If we can achieve that, we're not going to achieve that all completely through value engineering. We know that, but we may be able to change. We may be able to achieve that through some design alterations, and that's what we're looking to try.
Could you give us some examples, Deputy Leadbeater, of what those might be? Just the type of things those might be.
It's looking at some of the, when I've examined some of the costings, and unless you've got a construction background, it's difficult for me to try and explain to you, and you might have the structural parts of the existing building, and they've looked at ways that they're going to get around teething into those bits, and so they say, well, you're going to need to put this stanchion here, you're going to need this element of steel, you're going to need this. These are assumptions being made by our cost estimators. When it comes to the actual building of this, the contractors may look at it and say, well, no, we haven't got to do that, we can do it this way. So we're still at a very early stage, we're still at OBC stage at this point. So we're very, very hopeful that we can try and get the costs down from the estimates that we've been given. We'd like to get, our ultimate aim is to try and get within the original cost envelope.
But of course, observations from contractors could push the figure both ways.
Yes, they could do, but I think the cost estimates we've been given a word on the side of caution.
Okay.
So they said, well, okay, we'll allow 5 million for that, when you might be able to get away with 2.5 million.
Okay, can I come back to something else you said, Deputy Leadbeater, when you mentioned about this REBA stage you thought that you were at? Am I right in thinking that the staff who didn't disclose the increase in cost were also the ones who informed you about the wrong REBA stage?
Yes.
Okay, thank you. Deputy Dougleon, did you have a supplementary?
I think so, because I think that exactly that point, for me, highlights the need for someone in the room, someone who's a politician, who's got ultimate responsibility and needs to be held to account for the spend of taxpayers' money, that had someone been in the room to understand that detail, then there could have been challenge questions asked at the time within that space. So I just wanted to make that comment. I think that it highlights the need.
I don't think that any politician could have challenged. You'd need, because, and I don't think it would be right to challenge at an early stage. If you're talking about the assumptions that have been made by our cost estimators, which is what I was referring to.
I'm talking about the stages that you'd moved through from REBA, all the REBA stages, which you would have been kept up to date with, that you, someone who was sitting on a governance board would have been able to understand the timeline of progression and would have been able to challenge that timeline of progression.
Well, yeah, I mean, we can look back in hindsight and say that may be the case, but we've been advised by our officers that we're also sat on those governance boards that necessarily wasn't the case. The costings that we were given for REBA Stage 3 were the costings that we shared with the public and with our colleagues in the States.
And as I mentioned, we were in the room as States members from our professionals saying we need 120 million to progress this project. None of those people who are now no longer with us stood up and said, by the way, that's the wrong figure because I've got this one. If we needed to ask for a different figure, we would have asked for a different figure. We rely on the professionals to advise us. And as we go through REBA stages, as Mark says, we will be doing the challenges, which is what we do. It's very unfortunate, and my apologies as well, that it's gone up by a possible 30 million. Yeah.
One of the reasons you've given for continuing with phase 2 straight after phase 1 was to keep the contractor on site. I think we heard that at our last scrutiny hearing with health, to ensure continuity and also the benefits of familiarity with the site as well. Is that still the position? And if so, how will you ensure the rigour that would normally come from a competitive and open tendering process?
Well, this is now going to be the difficulty. We were not it. The original project was meant to carry on seamlessly from phase 1 to phase 2. The learning that the contractor, which is builder, it was considerable, working on a live environment where you've got patients and knitting their services in with ours is quite complex. Unfortunately, the P&R didn't provide us with the funding earlier to move forward. We had this stasis for a year and a half. Then it was left that we were no longer going to be a project for this term. So from that point of view, that started to widen that gap. So any advantages that we may have had then are probably now not so tangible. The difficulty will be which other contractor locally could do the job. And we have seen what happens when we've had contractors from outside. I've been in politics long enough to know that hasn't always gone so well either. So we're in a difficult position as a small island of 60,000.
So could you just remind us then, Deputy Bride, of the timelines, because it was intended this seamless transition from phase 1 into phase 2. When does phase 1 now finish, and when is the earliest you can hope that phase 2 might start?
Well, phase 1 finishes, and I'll be corrected, this summer, and I think fitting out by end of October.
Well, by autumn. We hope to
By
have
autumn.
the first service users in autumn.
When would you think we might have a spade in the ground, assuming that we're able to be within our cost envelope and done all the work which for the next 6 months which we're doing and reevaluating where we are?
Well, the original planning was always 2025, but obviously now we're going through the value engineering exercise. We've been given 5 to 6 months as a guideline of doing that work. We're going to have to see what the outcome of that is, and we're going to have to bring that back. So I'm not in a position to be able to state a date at this point in time.
And when you say bring that back, will that be to the health board, or will it be to the wider states?
All through our normal governance processes, absolutely, through to
It will come to the board, and as I said, in the States, if it's outside of our envelope, we will need to come to the States to ask for further funding. But if we're inside the envelope, then I believe that P&R will be in a position to sign us off. But of course, you also have to be very careful about anything that's changed substantially, because as Mark says, it's fairly critical that we try and make sure that the main elements of our project go ahead, because otherwise we're not going to have the capacity for our islanders who are desperately now. I've got a waiting list of people who need to be treated, and I haven't got the capacity to do it.
I think please
I
carry
just
on.
wanted to add to that, because you talked about the wish of the committee not to have RIOs decant from the site completely. And that's not the intention at all, because there is advanced works ahead of phase 2 that will need to be completed, and those will need to be completed if phase 2 goes ahead anyway. So there are bits of work that need to be done on the campus in between the 2 phases. So the hope is that there will be a smaller team still on site carrying out those works while we go through the value engineering and the design review process.
So those works would still be done even if you are then in a position where you have to come back to the Assembly and take your chances on approval of additional funding?
I think some of the works will need to be completed anyway, regardless if phase 2 goes ahead.
Yeah.
Right, so they're not works specifically for phase 2 that you're referring to?
Things like Giffard Roof, I think, is one. Is it Giffard?
Yeah, the roof needs to replace.
There's some
Right,
other,
thank you.
and some of the other services as well that we must make sure.
I think that's unless, did you have a supplementary? No, a suitable point. That we'll just take a brief comfort break. If I could ask everyone to be back at 4:30 for the second part. Thank you. Deputy Roffey.
Thank you. I want to take you back to where we started, I guess, which is about this tidal wave of demand for the services that you provide coming down the road. We've heard a lot about the physical response to it, the capital response to it. You want more laminar flow theatres, you want extend the pH, etc. But what about all the other aspects? What modelling have you done about how much demand there's going to be on your various parts of your service in, say, 5, 10 or 20 years?
Well, I think you're walking into SLAW's, supported living and ageing well.
We can get onto that, but it's not just about that.
Yeah, I mean, there's the again, public health has the figures probably better than I do, but the modelling is, I think, we're going to soon have double the number of over 85-year-olds. That will, it's fantastic that people are now living to the age that they are. When I started work, it was 70 years and 10 was your lot. We are now far exceeding that, but it will come with more and more comorbidities. But I think
I've no doubt that. I'm wondering whether what work you've done to quantify it, what that will mean in terms of orthopaedic procedures, what it will mean in terms of this, that, and the other.
That's all been done, and that's been factored into the hospital modernisation. But perhaps Dr. Raby could probably speak on that better than me.
We produced quite detailed predictions of the demand coming down the line, and that's been modelled up to 30 years forward as part of scoping the hospital modernisation. So we've modelled that with various assumptions, as I said earlier, about how heroic the assumptions we want to make about prevention, about community support, about things like the SLAW's agenda and how that might impact on preventing admissions and things. So we've got various models that show if this, then that, and various increases. They all show huge increases in demand, and that's what we modelled phase 2 on, to provide the right amount of beds, outpatient capacity, theatre capacity for the preferred. I say the preferred. The model we accepted as the most realistic model for Guernsey. That detail's all available, and it's a worrying piece of work.
I'm sure it is. Would it be a good idea to be sharing it more broadly with the states? Because this is going to be one of the biggest challenges the Assembly as a whole has to face over the next few years. We've looked at it through the lens of your request for the hospital modernisation, but that's just the bricks and mortar part, really. It's really the whole impact on the cost of healthcare I'd like to know more about.
Very much so, and it's exactly why we've asked Dr. Brink at Public Health to look at that issue. Dr. Brink.
So, thank you, Deputy Ruffy. I think this is a really, really important aspect. So there are 10 chronic diseases that are likely to increase, particularly in the 75 plus population. The challenge we have is how we then cope with that demand as these conditions increase. And we've used some modelling data from Jersey. So Jersey have done some quite detailed modelling on a collection of chronic conditions and their impact on bed capacity. So we've looked at that and what that means for Guernsey. So if you take our population demographic now and our population demographic in 20 years' time, in 2043, we will have, at the moment, 10% of our population are above 75, and it'll be 17% in 20 years' time. Now, the argument that has been put forward, if you really put prevention in, would you just increase people's longevity? And we've done quite a lot of work to show that we're probably at our ceiling of longevity age-wise. You might increase it a little bit, but you're not going to significantly increase it. So if you take those 10 chronic conditions and you model those on what our increase of bed capacity will be in hospital bed days in 20 years' time, you're looking at about a 30% increase in hospital bed days. So what we can say is that the current hospital capacity will not serve our needs. And that is the biggest and strongest argument for putting prevention in. And not only the very early prevention, the very upstream prevention, stopping people getting ill, but with people with chronic diseases, how do we keep them healthy and how do we keep them out of hospital? And it's that flattening of the curve.
Well, while you're here and talking about that, I'm going to do a question that was going to come later, but I don't want you to have to jump backwards and forwards. Are you comfortable as a committee, but Dr. Brink is here, with the cost and therefore accessibility of primary care? Because Dr. Brink keeps talking about the sooner you start treating these conditions, the less costly it is. So surely you want people to access primary care in a timely way, and yet we know that there are people in the island for whom that is a very expensive and challenging thing to do.
Absolutely, and of course there was a working party that started off at this term of government, which you actually sat on.
I did. I'm wondering when it's to start again.
As part of it, and we do have. I mean, first of all, we do have good doctors, and we have very good access to primary care. But you're absolutely right; it's the cost. It can be preventative or prohibitive for some people. Those who are very reasonably wealthy or comfortable, like most of the people in this room here, it's not a problem. For those who are on the lowest paid percentiles, again, that's not an issue because you know in social security you will cover that. It's the middle. It's that middle ground. We do provide a £12 grant. That could be, and one of the things we were looking at was redistributing that to make it more accessible to those who are just above income support levels. That hasn't, because of resources, unfortunately, hasn't really gone to gone as far as it would like. But if you're going to look at moving or wanting to make it a lower cost, I would imagine that the doctors will still need their sum, so therefore somebody else will have to pay. So whether that's the government or some other scheme, but there's not much in our budget because we're already up against it to be able to say, oh, and we're going to now give a further subsidy.
Okay, I'd love to explore that further, but I don't think we've got time today. So we're going back to this projection of building on Josie's projections that they've already done. As you say, you've said that means we need this many beds, this many whatever. I hate to just come back to money, but have you done financial projections of where it comes from, the public or the taxpayer or whatever, what the increasing cost of healthcare is going to be in Guernsey in, say, 10 or 20 years' time? Because I worry that maybe some in the community think you're crying wolf, and it would be useful to actually have that data.
Dr. Raby, would you be able to comment on that?
I don't think I've seen figures for that extra cost, but you can work it out from the staff you need to deliver the services. So I'm afraid I'm trying to think which document to point you to. Can we think about that and come back, because I'm just not coming up with the right document for.
So I can answer
Thank you.
on cost projections.
So this is Darren, who's our finance gentleman.
I mean, imagine I'm president of P&R and I'm asking, what sort of money are we going to have to find in 10 years' time? What can you point me towards?
So a number of modelling approaches have been taken, some with partners, including back to 2015 BDO, a baseline exercise across, well, basically finance-led, but using all state sort of committees and entities that ultimately informed where we are in terms of our funding investment plan and the GWP. So year on year, there is an allowance for health costs outside of inflation or any specific initiatives that's equivalent to 4 million per year. So that is effectively, and that's part of the challenge of the affordability for the state, but it's built in, and that's effectively recognising that there's a year-on-year increase through demand and predominantly the demographics. But of course, it doesn't fall evenly. We have step changes in cost. We'll have particular challenges in certain years, and that's what we're seeing as well. So there's capacity in the budget and in the terms of the planning, and then what we're doing really is reviewing how far out through that are we, and do we need to revisit that? And I think in terms of the sustainable healthcare modelling looking forward, it is, I think, due a revisit, as it were, in terms of those assumptions. The next opportunity for a baseline review and estimate would have been the FBC for phase 2, which would be the next natural point to do those costings, but obviously that's hospital specific. We would then broaden that out to look at broader care, children's services, etc., to do a holistic approach.
Yeah, the care in the community with the treatment that's required there and the prescriptions. I suppose what I'm trying to get at is, do you believe we need to look at an entirely different way of funding our health care? I mean, you mentioned incremental things like taking away free prescriptions from pensioners and putting up fees at A&E, but is it bigger than that? Are we really saying we either need a new health tax or we need to change the... I'm sort of going back to the question I was asking earlier. I was asking then, how do we divvy it up between the public and the taxpayer? Now I'm asking, how big is the thing that we have to divvy up, really?
I think you're right. We would only be looking at some of these other alternatives if there's nowhere else to go, and we are caught between either providing a service to islanders who have an entitlement to it, and absolutely so. But I would think that we need to, just as we can't provide services in this century on last century's income tax or taxes. The services we require will need a substantial increase in charges or raising funds. So whether that's income tax or GST or whatever product it is, if we want it to be provided universally, which is fine if you don't, but if you do and I do, then someone's going to have to pay more, and I think islanders will have to move that. Just as the Isle of Man, give you a classic there, they had their £27 million last year over their budget on healthcare. Overall, they are £40-odd million short. They've moved their income tax by 2%. I don't think that will cut it eventually.
That's on top of 20% VAT there.
Sorry?
That's on top of 20% VAT there.
So we are trying. We're almost. And perhaps I'm going to go off piste here a little bit, but
please do. There's always interesting when people.
Okay. Okay. I'm going to be really honest. I don't think, and I'm a last term politician. I'm not going to be standing again. And I think I'm partly to blame. I don't think we've raised enough tax. I don't think we've funded ourselves. We should be in a position now where we would have had the harbour walls repointed and built for 30 million. We should have had the hospital up and running. We should have had the key worker accommodation up and running. We should have had houses for our islanders up and built. But we're behind the curve.
Okay.
And so from my point of view, and I'm partly to blame because we want to do popularism. We want to make sure that we have more services and lower taxes, and those economics just don't work.
Okay. One more on this and that. Well, I think I've got to move on. But you started your first answer on this section was saying SLAWS was very important, and I'd like to understand better if there is a constrained social care sector and it's not growing to meet the demand, what impact is that going to have on the healthcare? Because they're not two totally separate entities, are they?
It will fall to our doorstep, as it's falling to our doorstep today.
So HSC will be supporting radical reforms to the social care funding and provision, will they?
Oh, that's a real political question.
Yeah, well, it's a political process.
From my point of view, yes, but I don't think it's going to be able to get through the states we have at the moment this political term. I think it's going to struggle. I think you're not going to be able to go in front of an elector and say, I want to increase your taxes or whatever it is because I want to provide care in the home for you and your relatives in older days. I think that's going to be a very hard sell. It's a different. As politicians, you stand individually and you want to be popular, you want to be voted for. It's not like where we've got in the UK where they've got parties and you've got one party pitched against another. You need to have a level of popularism to be able to get to be voted in. And I think, as we saw last term or at the start of this term, those who said we're going to get rid of waste and lower taxes got elected in, and then suddenly found themselves in a different position when they actually looked at the books.
Okay.
I hear what you say. I think it's going to struggle to get through. And although it's the right thing to do, I think with the social media and the media generally, plus with the election coming up, I think it's going to be pushing water uphill.
You feel Gans is uncomfortable. We'll have to stop at that.
That is not what I said, Deputy Roffey. Please withdraw that.
I withdraw that. I'd love to come back to your current waiting list if I get a chance later on, but I'm going to hand back to the chair.
Just add something.
Just in terms, from an operational perspective, Deputy Roffey, yes, a whole system approach is required, and I hope that's what the middle pillar of GWP will do, because you can't look at one part of the system without looking at unintended consequences across others, and that's what's been learnt in other parts of the world with taking a kind of piecemeal approach to the thing. As I've said in numerous presentations. If we were opening the health and social care system on Monday morning, it would not look like it does today.
While the Finance Director is sitting up with a microphone, could I just ask you, how are the forecasts for 2024 looking on your budget? Do you expect to remain within budget this year?
No.
No.
So where, to summarise, I think 2022 we were spent by 4 million. 2023 final figures after adjusting for the underspend on off island and returning funding to the health reserve was 4 million, and the latest forecast is just over 4 million. In each of those years we've got what we call medium-term challenges. We do have significant vacancies that we're trying to manage, and that's been resourced significantly within the budgeted FTE, but significantly above the budgeted cost, because we're covering at a premium. Over time, and obviously agency has been much discussed, and they're challenges that we are grappling with. We are looking at options and efficiencies, next steps into potential e-rostering to improve the tools, to give some mitigation, though there are multiple trusts across the UK who operate those systems and they're still overspending on agency. But it's about making those small efficiencies on a monthly basis that have a material effect over a year. So that's a regular focus for the operational team through our weekly challenge process. But those challenges do not go away. We're not funded for that premium. We're trying to manage and recruit to reduce that need for that premium. We are reliant. And then in conjunction with the challenges on accommodation, where effectively we need to bring those staff to the island, or where we successfully recruit, we're struggling to place those staff, they are at a premium cost as well. And those two combined are effectively driving the overspend.
Okay, so that's a significant part of the overspend relates
Absolutely,
to agency staff housing costs surrounding it.
Yes. So that in 2023, the overspend on staffing in total was 1.8 million. But for Agenda for Change, so frontline nursing, medical professionals, it was 3.4. So we're reliant on vacancies and other across the broader HSC to mitigate it, but it can't fully cover it.
Right.
And it's looking similar for this year. We will do what we can. We will look ahead to things like e-rostering, which is about managing ahead in real time and finding those small efficiencies. And it is small efficiencies. If you save an hour on every agency worker who we're currently employing, it's hundreds of thousands across a year. And that's kind of where we are. But those challenges will not be removed for the foreseeable future. But within a few years, they should be something we reduce and resolve.
Okay, thank you.
If I could just add on that it's the cost of agency which is pushing our budget over the envelope that we've been given. And I want to just, if I can, use this opportunity to bust one myth. Key worker housing is not being propagated by us, for agency staff. It's for permanent staff on the island that we want the key worker housing for. And I don't know how many times I have to say it, key worker housing, or housing for local people generally, is just so important to how we can run our business. And if I have politicians, very senior ones, who keep on about the fact that we're trying to house agency staff by building key worker accommodation. Nothing could be further from the truth. So I hope they're listening today, because I'm getting extremely cross that they're not able to understand the problem that we're facing with regard to recruitment. And having key worker housing is key to that.
Okay, I think that point is made.
Thank you.
Does the committee believe that the current model of providing secondary healthcare medicine, which is largely via the MSG, will continue to be sustainable beyond the life of the existing contract?
I personally think so. I think we've got we work in partnership with the MSG. I think they provide a very high standard of service. We are very fortunate. We have consultants. And there are other models, but I think the one we've got serves us extremely well. But I think I'll probably turn to Dr. Raby, because you're probably closer to that than me.
When the current MSG contract, secondary healthcare contract, was signed, there was a huge amount of work done by the states to ensure that it represented value for money, and those financial reviews, which Darren can tell you, to ensure that continues. So we continue to believe that we're getting a service for the money, and if we ever decide that it would be a lot cheaper or better quality to bring it in-house. That option's available to the States with it's a rolling contract with 5 years' notice.
Okay,
so at the moment, I would say we still believe we're getting value for money from the contract.
Okay. Deputy Ruffy, do you want to carry on at 21?
On waiting lists, yeah. I'll be brief. I would want to pick it under the covers both on orthopaedics and on gastroenterology, but let's deal with the latter because you've put stuff in the press about it today, which was quite striking. I mean, you've had an absolutely massive increase in demand. You've done a real special initiative last year that did any number of procedures. You've increased your capacity, and yet you're saying that the waiting list is still going up and there's nothing more that you can do about it, basically. As I read the press, I may have got that wrong. Is just tell us what the situation is.
Well, I think the situation is probably as you described, apart from the last sentence of yours, which is there's nothing else we can do. There's lots of things we can do about it, but most of them will require resources and funding.
Yeah, well, okay. So
there are things we can,
the resources available to you.
There are things we can do as a society to improve it, but whether or not we can get the funding to do them, whether that's a new surgical cube or something of that sort, so we can do cataract operations, etc., over here quicker and all. There are lots of things we can do, but they will all require funding and resources. And I think I'll ask, before I get cross, I'll ask Dr. Raby to carry on.
Can you just confirm the number on that waiting list? Was that correct? What was in the? Did I read something like 6,000?
The number on the number on the gastroenterology waiting list. The one I look at was last 493 last I looked, but you can add to that. You can add follow-ups and things, but that's the number on the waiting list as such. 493 last I looked, which was about 2 weeks ago because I was going on holiday. When we came to see you last, we told you that we were doing about 110 endoscopies every 2 weeks and every 2 months. The reason we say 2 months is because the waiting time is supposed to be 8 weeks. Yeah. So if you've got a waiting list of 110, we would have been in budget. So since then we're doing 250 every 2 weeks now, every 2 months now. We've gone from 110 to 250 in that time with local Guernsey capacity by having the 2 gastroenterologists, the nurse endoscopist, working the system ever so hard, and that's a fantastic success story. But in the same time, we have increased the number put onto the waiting list from 1,300 in 2022. To 1,900 in 2023. The growth is like that. Now, I think part of that was pent-up demand because GPs were holding things back because they knew there was a long waiting list. We did the waiting list initiative. GPs released some of that to us, but it isn't slowing down yet in 24, which is worrying. So we have increased our capacity locally hugely. We are still seeing huge increases in demand in that particular specialty. The other specialties don't look like that. Orthopaedics, we've added exactly the same number last year as the year before to the waiting list. It's just steady state. If we could do 2 more operations a week in orthopaedics, we'd be dealing with our demand. But it's 2 a week. We're falling behind, and the number is growing ever so slowly in orthopaedics, but it's growing. So those 2 specialties, very different pictures.
I wasn't being the least bit critical of what you were doing on gastroenterology. I'm just absolutely struck by the fact the amount that you have done, and the demand and waiting list is still going up. I just really wanted to ask what's the solution.
Well, I think we modelled that we think that what we're doing now can keep us in steady state. In the hospital modernisation, we move into the new theatres with the new endoscopy suite, and that will allow us much better throughput. But until then, I think we just suck it and see, because I think doing what we're doing, 250 cases locally every 2 months ought to be about right. But if I'm wrong, and if the numbers adding to the list keep doing that, we'll have to think again. We can't do much more with our current capacity. We would need more space, or we would need to do weekend lists, that sort of thing, as extraordinary measures, if I'm wrong.
Yeah, because it did say in the press that the reason was an ageing population, higher health demands. But you're actually saying that in this particular speciality, it's a little bit of a mystery as to what the demand is, because clearly the ageing population is not going to make that kind of percentage difference in the space of 1 year.
There's a huge demand for these investigations from the worried well. And it's prioritising those who potentially have cancer. It's very difficult work because some of those worried well do actually have cancer or something seriously wrong with them. But the amount of demand from the worried well is huge in that particular specialty.
Okay.
I don't know if it's fair to say.
Who is the gatekeeper for this? Is that the GPs or the specialist?
Yep. GPs refer to the gastroenterologist. The gastroenterologists have the right to turn down any referrals they consider to be inappropriate, but actually we test pretty carefully at the GP stage. The GPs will do a fit test, which is a test to, if they suspect cancer. It's a test that says it's worth doing an endoscopy on this patient, and we introduced that as part of demand management years ago, 3 or 4 years ago. So we're not putting a lot of rubbish on the waiting list, I don't think. But we will work closely with the gastroenterologists and GPs if we think there's anything else we can do. At the moment, the gastroenterologists don't tell me they're getting a lot of bad referrals. And I'm still hoping that it's pent-up demand from the years when there wasn't enough capacity.
That's very helpful, thank you. Deputy Fairclough, I think over to you.
Yeah, I'd like to turn to the electronic patient records. This has already been alluded to earlier on in the hearing. I understand that the new electronic patient record system will now be further delayed until at least the end of March next year, and that you are currently reviewing cost impacts. When do you expect to have that information?
Well, we only basically had the information to start with regard to the request that to mitigate risk we need to move the start date. Have we got a? I'll go to you, Dermot, on that.
Expect to have more detail within the next month. Teams are actively working on, as I say. Compared to the way I handled the OHM, we have verbally told committee on Tuesday, and we've requested that the team work on that now at pace, maybe quicker than a month, but look at the month. I think the key thing to remember is the previous EPR implementation didn't deliver the outcomes or efficiencies that was expected, so we're cognizant of the post-implementation review into that and getting this right. This is a massive piece of work in terms of all we've talked about in terms of sustainability, what health and care looks like in the future, so we want to make sure that we don't repeat the sins of the past.
I understand that you want to get it right, but I mean that presumably has always been the case. I mean, only 3 weeks ago States members were assured the project was on time and on budget. So what has changed in that time?
Well, I think we had how can I say this politically correctly? The States has had a checkered past with regard to electronics and computers and even your own review, I think, which was meant to be a short, sharp review into it, was meant to be producing the report on Agilicis in December 2023. Because it's so complex, you found it difficult, so you're now producing the report, I think, in this summer, 6 months later. We also have a very, very complex project actually to provide the service, and we've had a new director in place. Staffing has not always been as good as we would have liked for the last few years on this, so we're very pleased. We've got a new director in place, and he has advised us, I believe, if I'm wrong, Dermot, please put. He has advised that he needs a little bit more time to be absolutely certain, because it's such a high risk for us. We can't have patient records going wrong in the migration from one to the other. The mirroring has to be absolutely perfect. The staff have to be trained. New business practices need to be put in place to make it actually, to get the benefit from it. So hence we're taking that opportunity to delay the project. It may well be that it won't be as long. It may well be that by next end of March, it may be they may need some more time. But it's so important we get this right. I've been through some major projects in my banking days. Some of them done really well, and some of them are absolute catastrophes. So, have you got anything to add?
Is it fair to say that you've given particular political ownership of this to one of your members now as well?
Yeah, absolutely. And in fact, he's here today. Do you want to say anything? Sure. So, thanks, Aidan.
Deputy Matthews, a member of the Committee for Health and Social Care. And one of the things that we did when we looked at the partnership of purpose and programmes in general was we thought it would be useful to have some greater oversight, political oversights on the project boards, and EPR is one of the areas that I have an interest with. And so we'll be taking some position on the project board for the EPR programme.
So are you confident, Deputy Matthews, that once operational, the new system will allow for patient access to records as was originally envisaged?
Yeah, as confident as you can be. I mean, this is, it's been a very well planned project that's gone through a lot of detailed analysis in terms of its selection of the right software. The issues that we've had have not really been to do with the functionality of the software. It's been to do with things like recruitment and availability of infrastructure. So I don't have a level of concern about the functionality of the software. That's at the moment. I think I don't expect that to be an issue.
Is there any intention to come back to the States with this, as you are with the hospital modernisation work, or is this something you're going to manage as a committee?
Well, I think we've said that we will keep States members advised. If we need to come back to the States for anything, we will obviously come back to the States if we need to. But if we're within our cost envelope, then we're within our cost envelope. I mean, it's probably in hindsight, it was unfortunate the cost envelope was pared down early on from 20 million to 17.5, I think. But hey ho, that hindsight's a marvellous thing. But we need to get this piece is one of the key jigsaws of the partnership of purpose, so that once we've got a new management system in place and a new patient record, then we can start about thinking of integrating the doctors into it. Then we can start thinking about how St John's Ambulance could have that information in the ambulance. That means that they can then perhaps treat patients in their own home and not have to bring them to the hospital. So it's a massive piece, but we just have to get it right, because I would shiver to think of something like this going on. And so that's why we need to be absolutely confident. And hence, I'd rather take the delay and the criticism from States members and the public rather than have a mistake.
We also, it's as Dermot pointed out, and as Al has mentioned, this has only verbally been raised to the committee as recently as Tuesday, so we're not fully appraised of the full situation as yet. So we can't give you any more than we've given you at this point, but we can certainly get back to you once once officers have come back to us with a further paper, so we can fully understand the problem.
Thank you.
What we can probably say on that, we did have a previous replan of the live date, and it's based on the idea that when you're going live with a system, you need to make sure and you have full confidence that you've got the training in place, that the implementation will go smoothly and that things will go well. The last thing you really want to be doing is going in with a system early and not have that confidence. So we do need to make sure that we do this one right.
Okay, thank you. Deputy Dodian.
Thank you. Can we move on to medicinal cannabis? The state's figures show that 13,200 prescriptions were issued for medicinal cannabis in 2023. Is this in line with the forecast expectations as set out in the original policy proposals in 2019? And are we following NICE guidelines?
Well, I think when it comes to the previous policy letter, that was the previous committee. Their assumptions for the amount of prescriptions, I think was I think they drastically underestimated the amount of people that would be interested in procuring medicinal cannabis. I think that's safe to say. You allude to 13,000 prescriptions. I think what I've found all along is people ask how many prescriptions, but they fail to ask the question how many patients. Mm-hmm. So you can look at on a 12-month period, you'll generally get one patient having 12 prescriptions. Mm-hmm. So if you can do the maths yourself and figure out how many people. I think the last time we looked, there was about 1,550, something like that, people, patients locally with the 3 local clinics that are operating. I think there's only 2 local clinics at the moment. and there was about 100 people still using UK clinics and importing their medications from UK pharmacies.
Okay, thank you. Presumably your advisors, your expert advisors, are the same that the previous committee had, though, who would want to...
I couldn't tell you that, I'm sorry.
So anecdotally, there are increasing levels of diversion fraud. Have you seen a rise in psychosis or any increase in admittance to crevice on board for this condition?
Well, we had a Freedom of Information request come to the committee asking just that question some time ago. The problem is we don't routinely collect that data at the moment. What we need to do is start collecting that data going forward. So I think if you ask us that question in a year's time, then we can give you a better picture.
Okay, thank you. What controls have been put in place to ensure that those who may have comorbidities that may cause psychotic episodes are not prescribed medicinal cannabis?
I don't think the committee has... it's the consultants that prescribe the medicinal cannabis the same as they prescribe any medication, and it's not for the committee to tell clinicians what they cannot prescribe, whether it be medicinal cannabis or otherwise. But you talked before about diversion, and there's anecdotal evidence to support the claims that there is a diversion of medicinal cannabis. I think what we really need to get our head around is there's been a real big problem in Guernsey with the diversion of prescription medication across the board for decades now. Now, people are making a big deal, and rightly so, about medicinal cannabis being potentially diverted. But we've had fentanyl being diverted, we had opioids being diverted that have been killing people in Guernsey for a considerable period of time. And I've not had one politician come to me saying, what are you doing about this? I think we really have a problem with diversion of prescription medication in Guernsey, and it's something that we need to do something about. Law enforcement, again, I mean, it's very, very difficult for them to try and police this, but it's a problem in Guernsey. It's not a new problem. It's an age-old problem, and I think that we don't need to just narrow our focus into medicinal cannabis. I think we need to look more broadly at the bigger diversion piece.
Well, I'll ask a supplementary before I go to my final one, but given that you have got a focus on the broader picture, have you tried to bring this to the attention of the committee to prioritise it?
Well, what do we do? I mean, we've spoken about it. Yes, we've had conversations with the chief pharmacist, the previous chief pharmacist, with the state's prescribing officer. I myself have had last term and this term have made inquiries about what we can do about this. I mean, we've been reassured that and you can see if you look at the prescribing rates of some of the more dangerous prescription medications have gone down. If you look at the opiate replacement therapy, for example, I think when I came into HSC back in 2020, we had about 150, 160 people using opiate replacement therapy. The problem we have with that, because we haven't got people generally that are addicted to heroin in Guernsey, they're addicted to opiate replacement therapy, diverted opiate replacement therapy. So the more addicts we were getting, we were actually creating those addicts by giving people opiate replacement therapy that were then diverting it. Now, since I think in the last few years, that number of the 160 has come down to about 70, 75 people on opiate replacement therapy. It's a really, really good piece of work, because what the initiative that was put forward was that for that sort of medication, it has to be you have to get it given to you. You have to go to the pharmacy, and it has to be specifically given to you. There was issues with people trying to keep it in their mouth, blah blah blah, because addicts are quite resourceful in that sort of way. But I think we're going about it, certainly from that point of view, we're going about it in the right way. But it's a really broad piece that we need to work with primary care and law enforcement to be able, if we're going to make any headway whatsoever.
Okay.
Can I just add on, just ask Tina Bogle to add something, if you'd like to come forward. It's mainly just to make sure that you're baptised into this system.
Yes, so I'm Tina. I'm the new one. Well, I've been here for a year now, so I'm the chief pharmacist. So we know it's been raised to the committee and to myself that there is an issue with prescription diversion within the states of Guernsey. So we have been doing a lot of work to try and gather the data. It's anecdotal, and for me, I need that factual information so we can make informed decisions. So we are looking at that and work with Home and other areas to make sure we've got that information before we make any big policy decisions or changes. So yeah, we are looking at it, and hopefully we'll present that.
So Tina, my last question, you may not be able to answer it, but I'm going to just put it out there for the record. So at this time, would you be able to say whether you've received any information from any agencies or the Children and Young People's Board that would highlight any increased use or incidents by vulnerable children in regards to cannabis?
Yeah, so we've had previously anecdotal evidence raised to us. So as part of the safeguarding, we've been looking at collating that information and looking at incident reports, so encouraging people to actually, staff members that deal with those children or vulnerable people, to record those as incidents, so we can start looking at that information and collating it. So we know we have got an issue with young people accessing medicinal cannabis or other prescription medicines, but I just want to be really clear on what that is. So we are collating that data and encouraging our staff working with those young people to collate that and report it back to us, and we've got a working group that will be looking at that. So yeah,
it's very helpful, thank you.
You may want to stay there as well.
Oh, okay. Yes.
I don't know whether you need to be or not, but I want to talk about the subject of nice DAs. And obviously, many of them are pharmaceuticals, they're not all pharmaceuticals. I know we've got a presentation coming up in a few weeks about it as States members, but now we're in a public arena. How's the introduction of the policy on nice DAs gone from the HSE perspective?
I think it's gone very well. I think we've used the same company that advised us in the first time in putting in place the solutions for public health.
Not how's the review gone, but what's your experience been of being able to prescribe these drugs mainly that you weren't able to some years ago?
Well, the feedback, certainly I think we use Care Watch, who's in the room today as well. It's been very positive from patients with regard to their experience and our ability to basically move from, up to 30 quali and then up to a 40 quali where we are now. There are some significant challenges which will come if we move further, and even to stay the same will be significant challenges. But I probably would go to Tina at this stage.
Yeah, so in terms of feedback, do you mean? And I think in prescribing we've had good, we've uptaken the nice TAs that are appropriate. We have had obviously negative feedback from some patients that don't really understand why they can't access the drug for their nice TA. So it's just kind of making sure that we explain it well to patients and the public, understanding what drugs are available and why they can't have it. So the ones that are available that we've had really good uptake and really good positive patient feedback, it's where we've had to say no, unfortunately, to those people that don't qualify for that drug within that TA. So I think, does that answer the question, or do I need to?
Yeah, I think it does. I mean, and the obvious other side of the coin is, what's the cost been? What's your estimate of the annual cost of the change of policy that the States approved some years ago?
Yes, it's approximately 5 million, and I think, but some of this data will, if you can just sit on your hands for a couple of days.
I can, but the public won't necessarily be at the peninsula where, or you're going to make that a public presentation at that time.
No, I have found that when I do things to States members, it ends up in the media anyway. Bless. But I think it would be. I think we'd like to present to the States members first, and I'm sure we'll do some sort of announcement to the public as well afterwards.
Okay, but I picked up it's about £5 million a year. I suppose the obvious question is you still haven't gone all the way though. There are still Guernsey patients don't have access to the same drugs and treatments that UK patients would, because once an ICTA is approved, it's almost obligatory on UK health authorities. Are you comfortable with that, or would you like to move to parity with the UK?
I'm going to answer that just purely for myself. I would like to move personally, but I don't know what our committee's position is. But you do get, when you get to the higher levels of cost of drugs, the effectiveness of what you could use the money for, and you've been very keen about prevention. Would that money have been better spent on prevention, or not? Are we best to stay at 40,000 quali, or are we best to move to 50, or are we best to do all? There are some very difficult choices, and if you're giving me the money to do it all, fine. But if you're not, we've got some very difficult decisions to make. Can I just bring Dr. Raby in, because we've asked you this question?
we can spend all your money, and we mustn't. So there's going to be some hard decisions. If we want to go to the same, you know, the Cancer Drug Fund type funding that the UK has in place, that's a political decision. We'll take the money and we'll spend it, and some patients will benefit. But for me, the best next investment in healthcare and health and social care in Guernsey is to ring fence some money for prevention, because we will be thanked in 10, 20 years' time for doing that. And that's where I would put the money first. And if there's money left over after we've done that, let's look at where the next best spend is. But drugs wouldn't be my first choice.
Okay, my last question on pharmaceuticals, and probably my last one of the hearing. I noticed that the prescribing support unit's annual reports now several times have warned that the cost of the sort of generic drugs that are prescribed in very large numbers have been skyrocketing, really going up in recent years. What impact is that having on your budget? And is there anything that you can do about it?
Well, I mean, there's been a substantial... We've benefited in the past from the move to generic drugs, and I think there's been a lot of work done by Geraldine or Ian on that particular area. But I think I'm going to turn to Tina to...
Yeah. So generics are increasing, but we are trying to make savings in other areas and getting the rebates, the drugs at a lower price similar to the NHS. So it hasn't had a dramatic effect on the total cost of drugs at the moment. Okay. So hopefully it stays like that. But we do keep a really close eye on it, and we're in the process of doing the next annual report, so that will be out in a few months hopefully. And I think so far it's looking okay.
Thank you very much.
I just wanted to touch on maternal health and ask what the current percentage rate of elective non-medically induced C-sections is, and what the cost of these C-sections is to the States.
I can't tell you the figure at the moment because we were told to stop counting them. We were told to stop counting them because the evidence was that caesarean sections were a valid choice for mothers to make in terms of delivery. And if a mother wanted a caesarean section for no other reason than that they wanted it, they should be encouraged to make that choice. And that was a decision made in response to findings in the UK. Before that, we used to try very hard to drive caesarean section rates down. It was seen as good practice to drive caesarean section rates down to the lowest safe level, whatever that was, 20%, whatever it was. We have quite a high caesarean section rate here, and the reasons for that include that our maternity unit is far from our operating theatre, and if the obstetrician or the midwife is in doubt about the safety of that baby, when there's a transfer time that involves transferring the baby along a long corridor, into a lift, down and into another corridor to get them to theatre, and we know that takes about 8 minutes, in addition to the decision time, the mustering the team time, all that stuff. We are not well placed to deliver a baby very quickly. But you asked about elective. The fact is, elective sections are becoming more popular with mothers, and we do that when they ask for a section now. They get all the information to make an informed choice, but having had the information and having made their informed choice that they would prefer a caesarean section, we've been told to go ahead and do that. So I think we run about 45% total deliveries, something like that. But if I'm wrong, we'll send you the figures. That's not for elective, that's for combined elective and whatever. I'm probably miles off, but we'll send you the data.
So are we running a midwife-led service or a specialist service?
You can have a midwife-led delivery in our hospital, and we don't have a separate dedicated midwifery-led unit because the numbers we deliver are tiny. We deliver about 550 babies a year here, so we don't have a separate midwifery-led unit. But in our delivery section, a lot of deliveries are midwifery-led. More deliveries that need obstetrician input are defined in the same way as in the UK, and those would be the same. You know, they would get an obstetrician involved in their care.
But is it proportionate for an island of our size?
Yes. Women who choose to have a midwifery-led delivery and with no complications that makes that a safe option for them have that choice and take it. Yes.
But women don't have an option of a home birth.
We will try to oblige a home. We will try to facilitate home birth. We can't guarantee to do that because we don't have enough midwives to guarantee the safe rota in the hospital. So we've tried very hard to say, where we can, we will, but the fact is we can't. We can't offer that
I think
service.
that sounds like a new
24/7.
policy announcement that
Yeah,
Deputy
no,
Brouard is rather concerned about.
I may have misrepresented what the position is.
We do not offer a home birth service. That stopped last year.
No, it was before that, but yes.
Yeah, and there are many reasons why, including staffing and safety, etc. So it's not, you can have your birth at home, but it will be at your own risk and not ours. We recommend that pregnant mothers come to the hospital where we've got the best care that we can possibly give them on an island.
Can I come back to something you said in your answer to one of those questions, Dr. Raby, which was about it takes 8 minutes once a decision is made to transfer a woman to the operating theatre. And then you also said you have to muster the team. But surely mustering the team and pushing the trolley along the corridors and in the lift are things that happen concurrently?
Yeah, we do all of that, but the fact is, if I can make a decision to get this baby out now and push them through those double doors into that operating theatre next door, the baby will come out quicker than if I have to do all of that.
But when we've got the new, I accept that, but when we've got the new hospital, if we go ahead with that, presumably that anomaly will have been resolved.
Yes.
So at that point, it's still not going to make any difference to the elective rate, is it?
To the emergency rate. So if I think this baby's in trouble, and I've only got to go there, I'm more inclined to watch the CTG for a bit longer and see if it settles down rather than make the decision to call a section now. And that's where it will help us. But you're right, women who want an elective section or need an elective section because for the various reasons, placenta previa or previous sections, that sort of thing, they'll still need to have an elective section.
Okay, thank you.
Thank you. I've got one more question to ask, and I'm going on to another area that's been in the news recently about gender identity. HSC stated last year that at a clinical level it endorses the spirit of WPATH. WPATH stands for World Professional Association of Transgender Health, and on the basis of a recent and significant leak of internal files is an organisation which science, proceeding with treatment without informed consent, and which has led to medical malpractice on children and vulnerable adults. Further, Dr. Hilary Cass, in her recently published review, stated that WPATH guidelines were found by the University of York appraisal process to lack developmental rigour. Does the committee feel confident that it can continue to endorse the spirit of such an organisation and to contract with private clinics who state that they operate in accordance with WPATH standards of care?
Thank you. I'll take that one to start with. I believe we're working to the WPATH guidelines 7th. I don't think we have accepted the next level of the. But I'm going to very quickly. Hopefully, he's still behind me, hasn't left. Oh, he's at the end. Oh, even better. Dr. Dominic Bishop, who can probably advise us far better than I can.
So the WPATH guidelines from version 7 written in 2012 and were fairly uncontroversial, and they speak a lot about respect and dignity and free equal access to healthcare, non-discrimination. The WPATH version 8 changed quite significantly. They introduced new concepts and they also removed age barriers for certain treatments, and it was almost, the documents you're talking about were almost a WikiLeaks leak of professionals who had concerns about the 8th version, which hasn't been widely accepted. The difficulty, in all honesty, is this is a very evocative issue. It's a very difficult situation, and the people are very reticent to produce guidelines. It's the only thing that I've ever seen that doesn't have any nice guidelines, and I think people have been too worried to produce them. There are some NHS recommendations, but Hilary Cass is the first person to have actually taken on the topic more broadly. I think you also need to know that over the last 15 years, there's been a massive evolution in this cohort and the demographics of the people therein. So in 2009, for example, there were fewer than 50 children and young people referred to gender identity services. Last year there were 2,500, and they've completely changed in their demographic. So I think, is there a surprise that things are out of date? No, there isn't, because things have moved along so much. There is no one who's an expert in Guernsey, but we've never done anything in and outside of what the NHS recommends. We based our policy and our procedures on the NHS recommendations as were. The fact that we contracted a private clinic didn't mean that we changed those. We just prevented our community from having to wait 5 years from accessing that care. We didn't commission anything outside of the guidelines the NHS do on a daily basis.
You get round to asking your questions on primary care, I think.
Primary care,
We've got
speed it up somewhat. Yeah.
Three minutes left.
Deputy Breward, you mentioned earlier that we started this term with a working party looking at accessibility to primary care and the cost of primary care. I understood it was suspended because of the need to focus on Alderney, but so when's the work going to start again?
I think we've got a paper coming shortly on that particular topic. I don't have a date as to when it's starting again, but we do have, unfortunately, not a very large civil service in the island generally, and on this particular case we were relying on central services, which were then moved elsewhere for other things which were much more pressing at the time. But I've just checked with my secretary or the committee secretary if there's a date for primary care update.
So the joint committees, Policy and Resources and HSC, met about a month ago, earlier in April, and decided that, well, we're looking again at the scope of how much resource will need to be allocated to each of those work streams. There are some smaller projects in there, potentially some quicker wins that might enable some change, but it's to be scoped because the resources just weren't available to take it forward.
Okay.
I think it will get picked up as part of the strategic portfolio, the work on the sustainability of health and care. This is absolutely fundamental to that piece.
You mentioned earlier about the £12 grant. What's the HSC position on this? I mean, it was 50% of the cost of going to a GP when it was introduced. Now it's about a sixth. It seems pointless to let it slowly wither on the vine. Is that the policy, to let it wither on the vine, or would you like to increase it a lot to help accessibility, or would you want to scrap it, which I think you hinted you might do earlier?
Well, to be fair, it was ESS who let it wither on the vine. We've only picked it up.
I know my predecessors did that. Yeah, I know. Yeah.
Thank you. So you know, it is a conundrum. If you want to increase it, that money will have to come from somewhere, or something else. It doesn't happen. That's going to be the dilemma. And I think from the work that you and I did on it, we discovered that the only thing we could do is move the deck chairs around. So it was making the grant move perhaps to somewhere where it did more good. But somebody will be upset because they won't have that grant anymore. And that's going to be the difficulty going forward.
Okay, because we've got 1 minute left, I'd like to ask, what questions should we have asked that would have been revelationary in your response? What's happening at HSC that you think that the island would be interested in knowing about? Or is nothing else happening beyond what we've asked you about today?
Dr. Raby.
We have saved the island £750,000 a year by reviewing the oxygen service, and nobody knows.
So you've done what, sorry? You've
reviewed the respiratory team have looked at the oxygen contracts over the last couple of years, and they've put in savings of £750,000 a year, and nobody notices, because when we do really efficient things, it just goes unsaid. So I'm really proud of that.
I'm delighted that we managed to, and Deputy Rockey's managed to afford you the platform to make that announcement. So I think that brings us nicely to 5:30 and the close. So thank you to all of the witnesses in both rows here for attending and increasing the public awareness of what HSC does. We undertake regular hearings, as you know, and we're in the process of scheduling the next one. Deputy Breward.
Yeah, again, can I say thank you, Chair, for the questions and the manner in which they were asked, and can I also just thank my top table team and my other top table team behind us, whether they were used or not. So thank you very much.
Okay, well, thank you everybody, and the hearing's now closed.